The following recording is an extract from the BBS UK Medical Information Booklet and includes information about some of the secondary features of Bardet-Biedl syndrome, BBS. Information about the primary features of BBS, genetics, diagnosis and family planning, the specialist BBS clinics and the charity. BBS UK can be found on the BBS UK YouTube channel and on the BBS UK website. The medical information booklet can also be downloaded from the BBS UK website www.bbsuk.org.uk. The information contained within the medical information booklet has been provided and checked by the BBS Specialist Clinics team and where possible is supported by research and published articles. A full list of references can be obtained from tonia.heimers@bbsuk.org.uk. Bardet-Biedl syndrome clinical features and presentation. Additional features. Speech and language. Many children with BPS present with speech and language difficulties. It is very common for first words to emerge late. The difficulties may range from mild to severe, and there can be problems across a range of communication skills, or just in one area. Following are some examples of the types of difficulties that can occur. Expressive language impairment, including slow acquisition of new words, difficulties putting sentences together, and difficulties describing a sequence of events or telling a story. Difficulties with receptive language, including difficulties with understanding words and sentences, difficulties following stories and more abstract language within the classroom and at home. Impaired social communication skills. Some children may have diagnosis of autism. Speech development can be very delayed. Some children do not babble when they are young. Other children do not develop speech sounds in the expected pattern, or they have unusual speech patterns, including disordered speech and/or dyspraxic speech patterns. The voice can be high-pitched. Resonance can be hypernasal. Treatment. A referral to speech and language therapy should be made at the first signs of speech and language difficulties. An assessment of the child's difficulties can then be made and specialist advice and treatment be provided early. Hearing impairment, if present, will contribute to speech and language difficulties. For example, if conductive hearing loss is present during the preschool years and is left untreated, this will have a negative impact on speech and language development. Hearing difficulties should be actively managed as soon as they are detected. For further information and support, www.ican.org.uk, www.talkingpoint.org.uk, www.afasic.org.uk, www.autism.org.uk, www.dyspraxiafoundation.org.uk, www.macathon.org. Neurological abnormalities. Ataxia, a group of disorders that affect coordination, balance, and speech, impaired coordination, and mild hypertonia, a condition marked by an abnormal increase in muscle tension and a reduced ability of a muscle to stretch, are reported in significant number of individuals. Low muscle tone is common amongst BBS patients of all ages. Some limited brain MRI studies have shown that some patients with BBS have smaller, unusually formed hippocampi and that there is a tendency towards decreased overall white matter. However, it is not clear if or how this affects neurocognition. A number of patients with BBS report difficulties with memory function. Hearing. Conductive hearing loss, almost always caused by glue ear, affects many children with BBS. This often resolves spontaneously or with treatment by adulthood. A minority of patients with BBS have sensorineural deafness. At diagnosis, assessment should include audiogram, audiometry, tympanogram, auditory evoked potentials. Follow-up assessment should include yearly examination, audiometry, detect glue ear, acute and chronic otitis media, which can lead to conductive hearing loss. Treatment: glue ear management, myringotomy tubes and/or hearing aids. Digestive system. Hirschsprung's disease occurs more frequently in Bardet-Biedl syndrome than in the general population, but the incidence is unknown. In this condition, a section of the bowel is permanently narrowed and unable to relax. This causes a build-up of stool and forms a blockage. It has been reported in a number of individuals with Bardet-Biedl syndrome and should be suspected in babies who take longer than usual to pass meconium, particularly in the context of a swollen abdomen and bilious vomit. In older children and adults, it often presents with a swollen abdomen, poor appetite, and constipation that does not respond to any of the usual treatments. Orthopedic abnormalities. Examination and early identification of scoliosis, curvature of the spine, genu valga, knock knee, genu vara, bow leg, and pes planus, flat foot, will allow for early intervention/treatment and may avoid unnecessary discomfort. Physiotherapy and orthotic referral should be considered. Early orthotic intervention and supportive footwear/insoles will ease discomfort and protect feet against further damage. Liver. Fibrocystic and fibrotic liver diseases have been reported in a very small number of cases of BBS. More recently, there is an awareness of the likelihood of coexistent non-alcoholic fatty liver disease, NAFLD, that is driven by obesity and type 2 diabetes. This is a chronic condition that can evolve over many years. It can manifest within a spectrum of disease that ranges from simple fat accumulation, hepatic steatosis, that has few, if any, clinical consequences, to inflammation, steatohepatitis, and in some cases scarring that can lead to liver cirrhosis. It is progressive in some, but not all patients. Managing the condition relies on staging the severity of NAFLD and treating the conditions that predispose to it, namely reducing weight and optimizing blood sugar control in patients with diabetes. Assessment should include measurement of plasma ALT, AST, and GGT concentration, liver ultrasonography. Cardiovascular. Congenital heart disease has been reported in a minority of BPS patients. Dextrocardia, heart points to the right instead of the left, and occasionally complete situs inversus, where organs are positioned opposite to normal position, have been reported, but these are rare. However, hypertension is a common feature of Bardet-Biedl syndrome and often presents in childhood or early adulthood. It may occur as a result of other features contributing to metabolic syndrome in Bardet-Biedl syndrome, in particular obesity. It is imperative that hypertension is treated since it can contribute to renal deterioration. Both lifestyle modification and pharmacological intervention are encouraged. Assessment should include blood pressure monitoring, auscultation, ECG, echocardiography. Joints. A large number of patients with BBS report pain in weight-bearing joints, probably because of osteoarthritis. However, a small proportion also have abnormally hypermobile or lax joints, the cause of which is unknown, but may be associated with hypertonia, decreased muscle tone. Dental. Several people with BBS have unusually short tooth roots, especially of the front lower teeth. Crowding of the teeth necessitating prophylactic removal is common. The majority of patients have a high arched palate, Occasionally, enamel dysplasia is evident. Both of these abnormalities can increase susceptibility to tooth decay and loss. Regular dental supervision is advisable. Respiratory system. Many BBS patients in the UK are affected by asthma, allergy, and hay fever. Obstructive sleep apnea, OSA, is common and related to excess weight, particularly around the neck. This may be compounded by low muscle tone and soft palate discoordination. All patients should be questioned about their quality of sleep and the presence of daytime somnolence, excess sleepiness. Evidence suggesting obstructive sleep apnea should lead to referral for sleep studies and lung function assessments, as many BBS patients report that treatment, e.g. nocturnal CPAP devices, result in major benefits such as increased activity, weight loss, and lower blood pressure. This information is meant as a guide only. If you feel concerned about anything you have heard, please seek medical advice from your GP, consultant, or a member of the BBS Clinics team. We welcome your comments and feedback. Please send to info@bbsuk.org.uk or tonia.heimers@bbsuk.org.uk.